Okay, we've got 35 minutes to make it around the world, and we're already over time. So let's do this. If I could have the speakers come up, and I'll introduce you from my seat over there. What we'd like to do is give about 8 minutes to each speaker and to leave about 10 minutes of time for questions so we can have some discussion after we get done. Is this working? There we go. I'd like to introduce the first speaker, Dr. Charlie Haworth, who's the director of the Cambridge Center for Lung Infection and a consultant in respiratory medicine at the Royal Papworth Hospital. Charlie? So while the slides are coming up, we are trying to have a global perspective. Charlie will present the UK and the EU sort of epidemiology. We'll then move on to Won-Jung Koh from South Korea, who will give us an Asian perspective, and then Ted Marras from Toronto will give us a North American perspective.
Thank you. Well, thank you very much indeed for the invitation to talk today. It's an absolute honor to be here. I'm also really delighted that you invited me this year rather than next year, because following Brexit, you may not think that I really represent Europe in a true fashion. Now, so I'll give you a whistle-stop tour through some European epidemiology, and I'm going to start with the NTMnet study that looked at NTM results from pulmonary samples in 2008, and these originated from 43 laboratories and from 6,800 patients across Europe. What's important to point out is that although these patients isolated NTM, they were not necessarily patients with NTM pulmonary disease as defined by the ATS and IDSA criteria. But as you can see, Mycobacterium avium complex is the most common NTM, and within the complex, Mycobacterium avium was the most common subspecies. Then it's followed by the Gordoni, which is probably irrelevant, then the rapid growers, and then Xenopi. Moving on to a study from the UK, looking at the incidence of NTM isolation in England, Wales, and Northern Ireland. And a particular feature of this study is that all of the data was sourced from the 5 mycobacterial reference laboratories. And so at a population level, you can be confident that the data are accurate. And you can see that while over time between 2007 and 2012, extrapulmonary disease was stable, there was a marked increase from around 4 per 100,000 to 6 per 100,000 from pulmonary sites. And you can see that the majority of this increase in isolation was due to the increase in MAC isolation. Now moving on to a study from Denmark, a pivotal study, population-based, all adults in Denmark with at least one positive NTM sample between 1997 and 2008. And this, again, was possible to do because there's only one mycobacterial reference lab in Denmark. And they showed that there was a mean annual rate of NTM pulmonary disease of 1 per 100,000 person years. And interestingly, this was stable over the 12 years of the study. Sadly, 5-year mortality was 40%. Xenopi was associated with a worse prognosis and greater health comorbidity, increased age, male sex were predictors of death. And then a subsequent study looking at the risk of developing NTM pulmonary disease in the same population showed that having a background chronic respiratory disease was associated with a 16-fold increased risk of developing NTM pulmonary disease. And you can see in the line below that unbelievably, bronchiectasis was associated with a 188-fold increased risk. Another pivotal finding of this study was that among people with COPD, the risk of developing NTM pulmonary disease was associated with the use, dose, and type of inhaled corticosteroid, with fluticasone being worse than budesonide. Back to the UK, a primary care-based study using a primary care database that is representative of 7% of the UK population. It showed that there was an average annual prevalence of NTM pulmonary disease of approximately 6 per 100,000, and again, in those with respiratory disease, a higher rate of 27 per 100,000. And the major risk factors for NTM pulmonary disease were previous TB, bronchiectasis, lung cancer, use of immunosuppressive medications, particularly in the sort of rheumatoid arthritis population, and oral corticosteroids. And now to Germany, showing a lower rate of NTM pulmonary disease. Between 2009 and 2014, there was a slight increase from 2.3 to 3.3 per 100,000. And you can see on the graph very nicely, it illustrates that the risk of developing disease is much increased the older that the patient population is. And in those over the age of 60, the prevalence was approximately 6.5 per 100,000. And in a subsequent study of 125 new patients that were matched with 1,250 controls and followed for 39 months, they showed that patients with NTM-PD had a mortality rate of 22% over that period compared to 6% in controls. Patients had 3 times higher hospitalization and a 4 times higher health expenditure, showing a very significant burden. And then I just wanted to finish by showing some preliminary data from the European Bronchiectasis and NTM registry platform. As you may know, the Bronchiectasis registry has been going for a number of years and has almost 15,000 patients with bronchiectasis enrolled. The NTM registry has only been going since last July, and so is significantly smaller. While the NTM registry has much more detail, there are already some useful outputs from the bronchiectasis registry. And you can see that 880 patients have NTM pulmonary disease as defined by the ATS-IDSA criteria. 69% of those have avium, 13% abscessus, and as you can see from the figure, it's quite interesting that almost no patients, less than 5 patients, had Xenopy. But of the overall group, 71% were female, an average age of 65 years. Now, if you compare patients with bronchiectasis and NTM compared to those with bronchiectasis alone, the NTM patients were older, more likely to be female, had a lower BMI, and perhaps, as you would suspect, there was more middle lobe disease. They also had a worse quality of life as measured by the QOL-B. But interestingly, although the patients with NTM pulmonary disease had a worse quality of life, they actually had a lower exacerbation frequency than the patients with just bronchiectasis. And finally, through the prospective nature of this registry, we're able to look at the risk factors for developing NTM pulmonary disease in the bronchiectasis population. So of the 4,000 patients with bronchiectasis without NTM pulmonary disease at the start of the study, they were followed for a total of 8,000 years, so approximately 2 years per patient. And during this period, there were 58 new cases of ATS-defined disease. And this was associated with older age, female sex, again, inhaled corticosteroids, a low body mass index, and a history of ABPA. Interestingly, the severity of the underlying bronchiectasis was not associated with the risk of developing NTM-PD. So in summary, from Europe, MAC is the most common cause of NTM pulmonary disease. The mean annual incidence is approximately 1 per 100,000 person years. The annual prevalence varies country to country, but is around 3 to 6 per 100,000. It's likely increasing, particularly in the elderly. And approximately 5% of patients with bronchiectasis in the registry are also known to have NTM pulmonary disease. Thanks very much.
Our next speaker is Dr. Won-Jung Koh. He's a staff physician in the Division of Pulmonary and Critical Care Medicine at Samsung Medical Center and a professor of medicine at Sungkyunkwan University in Seoul.
My name is Won-Jung Koh. I'm a respiratory physician from South Korea. It's my great pleasure and honor to be here to talk about the NTM epidemiology in Asia, especially in East Asian countries, including South Korea, Japan, and China. Oh, thank you. And I'd like to talk about to show you the general picture in the NTM epidemiology in East Asian countries rather than the detailed information, because one of the reasons is the majority of the audience is the non-Asian people. I have received the consultation fee from in-semester last year, not associated with today's talk. This is very important and interesting study in epidemiology study in Hawaii from 2005 to 2013. The over period prevalence, that simply means that number of people who were suffering from the NTM infection and NTM pulmonary disease. As you can see, the number of cases of NTM, number of patients with NTM isolation, blue bar, or NTM pulmonary disease, orange bar, the number is much higher in Chinese, Japanese, Korean, and East Asian people compared to white and native Hawaiian and the Pacific Islanders. East Asians are really more susceptible to NTM organisms. I'm not sure, but this study suggests that Asians are more susceptible to NTM compared to white people. These features are incidence of NTM pulmonary in Japan from 1975 to 2015. You can see very, very sharp increase of incidence of NTM pulmonary disease during recent decades. In 2014, the incidence of NTM pulmonary disease is around 15 per 100,000 persons per year, 15. This study is from South Korea, this study using national health insurance data. As you can see, in recent year, in 2016, the incidence of pulmonary disease per year is around 19 per 100,000 per year. This study using the health insurance claim data, but we don't know that these figures is actually true incidence of a pulmonary disease. These cases really meet the diagnostic criteria, especially microbiology criteria of NTM pulmonary disease. But these figures is true in Japan and in South Korea. The incidence of pulmonary disease is very, very high, the highest countries around the world. That is the reason that Japanese doctors and the Korean doctors are very, very interested in NTM pulmonary disease nowadays. Regarding the etiologic organisms of NTM pulmonary disease, Dr. Haworth said, Mycobacterium avium complex, MAC, is the most common organisms of NTM pulmonary disease in East Asian countries, especially in Japan, more than 90%, in South Korea, 70 to 80% is MAC. But interestingly, the Mycobacterium abscessus, the proportion of Mycobacterium abscessus is relatively higher in East Asian countries compared to Western countries, especially South Korea, mainland China, especially in southern part in mainland China, including Shanghai and the Shandong area, and Taipei, Taiwan. The proportion in these areas, the proportion of M. abscessus is even 20 to 30% among all NTM pulmonary disease. This is a really, really huge problem in these areas. First, among MAC. As you know, Mycobacterium avium complex is mainly composed, and traditionally composed of two major organisms, Mycobacterium avium and Mycobacterium intracellare. In many laboratories reported MAC, just MAC, that they did not differentiate avium versus Mycobacterium intracellare. But in East Asian countries, many clinical laboratories can differentiate the avium versus intracellare and report to the physicians. And we can know the proportion of avium and intracellare in many countries. In Japan, the predominant organisms are Mycobacterium avium, 2/3 of MAC patients, and Mycobacterium intracellare is 1/3 of MAC patients. The geographic distribution is different. Mycobacterium avium is predominant in northern eastern part of Japan, and Mycobacterium intracellare is more predominant in west and the southern part in Japan. In mainland China, contrary, Mycobacterium intracellare is a major organism among MAC patients. In northern part of mainland China, almost 100% of patients were suffering from Mycobacterium intracellare infection among MAC patients. In southern parts of mainland China, the ratio of Mycobacterium avium infection is increasing. In our country, South Korea, as you know, South Korea is located between mainland China and Japan. And in South Korea, the proportion of Mycobacterium avium and Mycobacterium intracellare is similar, equal. But interestingly, the proportion of Mycobacterium avium is steadily increasing in our country, and we are close to Japanese situation, in my personal opinion. What is the clinical implication of differentiation of Mycobacterium avium and Mycobacterium intracellare? This is our institutional experience. The prognosis, the y-axis is the survival rate, and the x-axis means the years after diagnosis of NTM pulmonary disease. As you can see, after the diagnosis, 10-year survival rate, 15-year survival rate is lower in patients with Mycobacterium intracellare infection compared to Mycobacterium avium infection. As I said earlier, in East Asian countries, the proportion of Mycobacterium abscessus is relatively higher in all NTM etiologic organisms. The Mycobacterium abscessus includes the three organisms. The name is still debate, but three bugs, Abscessus macilliens and Bolletii. In East Asian countries, the most interesting finding is the proportion of macilliens is very high, similar in the 50% is abscessus around 50, 40 to 50, 55% is caused macilliens. The proportion of Mycobacterium bolletii is relatively very rare. Then, in East Asian countries, Japan, China, Taiwan, Korea, as we can see, many patients of macilliens infection among abscessus patients. This slide shows that the prognosis, the survival, long-term survival rate is different between macilliens and abscessus. The survival rate, long-term survival rate is lower, much lower in patients with abscessus infection compared to macilliens infection. In conclusion, regarding the epidemiology of NTM pulmonary disease in East Asia, the incidence and the prevalence are really rapidly increasing East Asian countries, including South Korea and Japan. MAC is the most common etiologic organisms, but the proportion of Mycobacterium avium and intracellare proportions are different between countries. Mycobacterium abscessus macilliens are relatively common in East Asian countries, and the proportion of Mycobacterium maturiens is higher compared to Western countries. The prognosis in patients with NTM pulmonary disease is different according to etiology organisms. For example, avian versus intracellular, abscessus versus maturiens. Then precise identification of these microorganisms is important in clinical practice and future clinical study. Thank you so much.
And our final speaker in this panel is Dr. Ted Marras, who's a staff respirologist at the University Health Network and associate professor of medicine at the University of Toronto.
Dr. Olivier, and thank you to the organizers for inviting me to speak today. It's really a tremendous honor to come and speak with all these incredibly smart colleagues who teach me so much and answer my emails occasionally when I have problems. So what I'd like to do in 8 minutes or so, talk to you a little bit about the epidemiology of NTM in North America, and I'd like to break this up into four main objectives. One is a little bit about the numbers, the frequency of the disease, and the fact that it varies by geographic area. The second is the species variability, specifically the proportion of species that we see that cause disease, that reflects to some extent what Dr. Haworth and Dr. Koh showed us from East Asia, and there is some variability in that by geography as well. The third issue is temporal trends. Thank you. Thanks very much. And the third objective is about temporal trends, and the fourth one is about mortality. So before I get into those specifically, I wanted to reiterate what the preceding speakers have already gone over, perhaps a little more explicitly. And we need to remind ourselves that NTM is not a reportable disease. And it's also, as was pointed out, I guess by Dr. Koh, that to know that a patient has NTM, we need microbiological, clinical, and radiological data. We need all that integrated to decide whether or not patient A has disease. And then we need that data for everyone in a population to get accurate epidemiologic information. And unfortunately, that doesn't exist. So researchers have done used various methods to come up with what is hopefully fairly accurate data in different parts of the world. In North America, I've selected these 6 studies to compile, and because I think they reflect probably 6 of the best fairly recent studies that present epidemiology in our region. I would like to, for the moment, exclude Dr. Jemian's study that was limited to Medicare patients who were at least 65 years of age. So let's focus on the bottom 5 studies that looked at all members of the population. And the median value for annual prevalence was 9.8 per 100,000, 9.8 per 100,000 per year. Compared with, say, tuberculosis in Ontario, where I come from, that's about twice as common. Now, that's annual prevalence. I think that just gives us a proportion, a fraction of the true burden of disease. And for a few years, Dr. Winthrop's group, Dr. Prevost's group, and Jemian and myself, we were exploring using period prevalence as perhaps a more accurate measure of population burden of NTM. And I'd like to really just focus on the Ontario study down here. We looked at a 5-year period. The number of people who had NTM disease at some point during that period. We selected 5 years because of the survival of patients, the relatively low cure rates, high recurrence rates, etc. And we came up with a number of about 40 per 100,000. I think that value is much closer to reality for the population burden in Ontario. The next area is to think about the species distribution, and I've selected 6 studies here that I think are relatively contemporary and relatively reliable at telling us what the species distribution was in those areas. There's one from Canada, the Ontario study. We have Hawaii, and the rest from mainland US. And you can see in all 6 studies, MAC was the most common, not a species. We've already heard it's a complex of species. It's multiple species. But be that as it may, these are the data we have. 64 to 86% of cases due to MAC. Second most common, the rapidly growing mycobacteria. I apologize for lumping them together, but that's the state of the data. I would say, though, that this is largely driven by Mycobacterium abscessus, and M. abscessus is the driver of lung disease in this group. So let's say M. abscessus seems to be second most common if you put all of North America together. Third, Mycobacterium xenopi, and fourth, M. kansasi. Regarding geography, there are important differences. There are important differences in overall prevalence of NTM. This map comes from an abstract presented at ATS 2 years ago using a managed care claims database, and you can see some states that are in very dark blue, like in the Northeast, the Southeast, and a few other areas, had a prevalence in 2015 of greater than 17 per 100,000, whereas some states that were pale, Wyoming, for example, a prevalence of only up to 5 per 100,000. So geography affects overall NTM prevalence. It also affects species distribution. This is one example. Where I'm from, in the Great Lakes area, we have a lot of xenopi. There's really precious little xenopi elsewhere in the US when you get away from the Great Lakes. This map, however, talks about the proportion of NTM isolates that are MAC. And you can see up in the Northeast and in one other region, 80 to 92% were MAC. However, if you look through the central US, 60 to 70% of isolates were MAC. So there is geographic variability for species distribution as well. One slide on temporal trends. It's a boring slide. There's no nice pictures like the other presenters showed us. I apologize for that. But I just would have a hard time putting all 6 of these studies onto one slide. Every study that has looked at the epidemiology over time in North America in the last couple of decades has shown an increase. The median increase in incidence, 3.7% per year. So year over year, 3.7%. Median increase in prevalence, 8.5% increase every year. And I'd love to have the opportunity to discuss that during the discussion period that will follow. And finally, survival. I've selected only 3 studies because they were all large and either population-based or quasi-population-based. Everyone in Ontario, a managed care insurance database that was across the US, and a large Medicare sample of 39,000 patients with NTM pulmonary disease. Different definitions of NTM-PD, but in each one, the patients were matched with uninfected controls from the same population, matched by age, matched by sex, and various statistical measures were taken to control for other differences in health that were between NTM and non-NTM patients. And the bottom line is looking at this third column, mortality risk, the hazard ratio. In every study, the hazard ratio was above 1. So what does that mean? If you take a look, for example, at the managed care claims database, 2.06, at any point in time, an NTM patient was twice as likely to die as the patient who was uninfected with NTM. This does not say people are dying from NTM, but people with NTM lung disease have a higher mortality. This was consistent, as you can see in all the studies. So to summarize, I spoke a little bit about frequency. I think it is a moderately common disease in North America. I think MAC is the most common cause. Well, I know MAC is the most common cause, probably followed by abscessus if you put all of North America together. Geography really drives the variability. The temporal trend studies show that the prevalence is definitely increasing, and there is a substantial mortality among patients who have NTM lung disease. Thank you.
I'd like to commend the speakers for staying on time for their respective talks. And we'll now have a few minutes for discussion. And as people are thinking up questions, each of you showed an increase in prevalence in your respective areas. And I was wondering if you could just discuss your opinion about what factors might be contributing to that and whether they're the same or different between the different geographic areas. Charlie.
Well, I guess it's probably due to a number of factors. I think we do believe that there is an increasing incidence and prevalence, but also I think awareness of the disease is increasing, and so physicians are looking for it more frequently, and therefore they're finding it more frequently.
I absolutely agree. The awareness of the physician in NTM lung disease is very, very increasing, and the one special situation in East Asian countries, including Japan and South Korea, we have an annual health checkup in elderly people. Then routine chest X-ray. Traditionally, the routine health checkup and chest X-ray can find the pulmonary TB, the purpose of the traditional purpose. But nowadays, the routine chest X-ray can detect some abnormalities. In Japan and South Korea, the access to the hospitalization very easy. That the cost of the medical cost is relatively low, especially in chest CT scan. And many people with the abnormality in chest X-ray can access chest CT and can abnormality in small bronchiectasis, some nodule, and then diagnosis NTM lung disease. This is some special situation in our countries. Yeah.
I agree with what the other speakers have said, and I'd like to elaborate on a couple of points. One is related to awareness and the medical checkups that Dr. Koh mentioned as well. I think that a decade or so ago, our radiology colleagues became much more aware of what NTM looks like on CT scans. And 20 or 25 years ago, we started using CT scans. Initially, it was an uncommon test. Now everyone with anything vaguely chest-related gets a CT scan. So I think we're finding cases that perhaps were always there. So I think that's part of it, is a surveillance kind of bias. But at the same time, I really, really feel that this is an increasingly common disease. The surveillance bias should have disappeared by now. It should have been saturated, but our numbers are still going up. So there has to be something else to it, and I don't know what that is. We could speculate, and all the experts in this room could speculate, but we don't know what it is. I think, however, it's multifactorial, and it's clearly becoming more common.
Great. We have at least a couple of microphones in the room, so if there are questions from the audience, please put your hand up and someone will get to you with the mic.
We have one right here.
Okay.
Hi, my name's Shoshana. I'm from UCSF. I find the species diversity extremely interesting, and one thing that comes to mind when we look at the U.S. data is the differences between the middle of America and the coasts. And the fact that we have so many people coming from other countries that live on the coast and not in the middle of the country, I'm curious if there's a way that we can tease out that data, or if it's been done to see if it's immigrants that are carrying MAC more, or if it's actually just the environment is more rich in MAC in the coast versus the middle of the country.
So I'll take a stab at that, although I think Dr. Koh presented some data that relates to it a little bit from Hawaii. In the Hawaiian group that was studied, there was a much higher rate in folks from Asian Pacific Islanders, highest in people of East Asian background, lowest in Caucasians. With their immigration status, I believe, was looked at, and it did not explain all of the susceptibility. What I mean by that is I don't think that patients brought their infection from elsewhere. I think that was related to some inherent susceptibility. Whether the species difference is shipped in or related to the geography is a great question. I would probably personally say that it is related to the geography. We see a really nice north-south gradient for abscesses, for example. Where I come from, abscesses is thank goodness, it's a very small piece of our pie. In the southern US, abscesses is a big piece of the pie. In Japan, as Dr. Koh showed us, a nice north-south gradient. In China, north-south gradient, lots of abscesses in the south. I think it's more geography.
Yes, I agree. That one of the reasons the proportion of Mycobacterium abscessus, the most difficult to treat NTM pulmonary disease, is relatively high in South Korea, southern part of Japan, southern part of mainland China, and Taiwan. The weather is wet and hot. I think that it's like a Florida. The weather proportion is one of the reasons that the Mycobacterium abscessus pulmonary disease is prevalent in the specific region in geographic area. I agree.
We have a question here.
Yes, I had a question. Are there any countries in the world that make NTM a reportable disease? And why is the U.S. so behind in making this a reportable disease?
So I've been interested and excited about reportability of NTM for quite a long time. And it was a reportable disease in Oregon for a couple of years. And to be truly reportable, the information has to be collected from a patient's record, including clinical symptoms, including imaging data. There have been periods of reportability in Australia. Dr. Thompson can tell us about that. And I think in both jurisdictions, what they evolved to was having a lab-based reportability. So they say, okay, we know how many people are isolating NTM in their sputum, so we have a reasonable guess based on that what the frequency of disease is. It's all about resources. It's so resource intensive to try and collect those case-based data.
Okay, I'm being told that we have time for one more question, so
One here.
please.
Okay, thank you. I lead a support group in Boston. My name is Marcy Weiner, and I know the other patients would be extremely interested in being able to get the slides themselves or handouts that I can distribute because the information is, they're always asking questions, and it's wonderful if they cannot be here to get those answers.
Amy, do you want to comment on that?
Mic up? Yeah, sure. So for the conference today, the videos and the slides will be up on our website in a few weeks. As for epidemiology, you're asking about specific handouts that answer questions about epidemiology. Yeah, sure, that's absolutely something we could work on.
Okay, thank you very much.